Good morning, everyone. Thank you for joining us. And so this morning's presentation is going to be by Dr. Harold Munnings. Dr. Harold Munnings is a gastroenterologist, musician, and Dr. Munnings, I'm sorry we did not have your music on for everyone to hear today. Author, past member of the Department of Internal Medicine, so he's no stranger to our medical community. I will let Dr. Munnings tell you a little bit about himself and his training before he starts. But Dr. Munnings is a graduate of the University of the West Indies, where he attained his MBBS. He is a fellow of the Royal College of London and the American College of Gastroenterology. He is presently the medical director for the Center of Digestive Health, which has been in existence since 1997. Dr. Munnings, welcome and thank you for speaking with us today. So we will now hand it over to Dr. Munnings, and while we get the technology going, please remember all your mics are muted. Your questions you can post in the chat box and I will read the questions after the meeting. In the chat box, we will also post the link for the feedback and to claim your CME, but that was also sent out in the email with the link for the meeting. It's also live on YouTube, so we will post that in the chat box as well. When the Zoom becomes full, please encourage your colleagues to join live on YouTube.
Good morning. Good morning, am I here?
Yes, you are here and we can see you.
Good morning, all. Let me see if I can get my screen up. Not yet a Zoom expert. We want to, no, we don't want to do that. Let's see. We want slides. And I want to share my screen. Share screen. There we go. So, we're talking about functional dyspepsia. We want to get rid of this. Share the screen, not the desktop. Share. How's this? Is my screen? Is my screen shared yet?
Yes, Dr. Munnings, your screen is shared. What you can do is just put it on full view.
On full view.
Yeah, slideshow.
There we go. There we go.
Perfect. We're seeing your slides.
Okay, thank you for the introduction. I don't know if I want to say more about my training except after UWI, I trained at the Bristol Royal Infirmary, University of Bristol, before coming home. So I have nothing really to disclose, no financial disclosures related to this presentation. I am dedicating this presentation in memory of my friend and our colleague, Dr. Judson Eneas, who has been, the COVID-19 epidemic has robbed him of us. I miss him dearly. This presentation is dedicated in his memory. I thought I'd throw in, I hope not as not too much of a distraction, some of the slides, some of the photographs taken at last year's Medical Association conference. But here's the outline of the lecture. It was pretty much as was posted, except I've made a couple of important changes, and that is that I'll spend a little more time illustrating the epidemiology. Where does functional dyspepsia fit in the scheme of things? And in the discussion of clinical features, I thought it would be more useful for clinicians to highlight the distinguishing features of functional dyspepsia rather than clutter minds and slides with a discussion of the differentiating features of each different type of dyspepsia. So what is dyspepsia? Literally, it means abnormal digestion. And it's the term we really want to use when there is lower chest or upper abdominal pain or discomfort that seems to be brought on by food or worsened by a meal. And there's a whole host of over-the-counter preparations that are designed for that. Let's start a timer so I can keep track. So we know that there are lots of causes of dyspepsia. The Mylanta commercial is something that gives me dyspepsia because they have this patient sitting on a doctor's examination table and his heart is thumping, and at the end of the commercial, the voiceover shows the doctor smiling and the patient saying, my doctor said, I have dyspepsia. My doctor said, Mylanta. And I hold my head and I say, well, geez, the doctor didn't tell him anything. The doctor didn't give him a diagnosis. The doctor just told him that he has an upset stomach, that food seems to, what you want the doctor to do is tell you what is causing your dyspepsia. And it could be functional, it could be gastroesophageal reflux disease, it can be gastritis, and we know that there are a number of causes of that. It could be peptic ulcer disease. It could be cholecystitis, pancreatitis. It might not be gastrointestinal disease at all. Cardiovascular disease is something that catches a number of people unawares. So what is functional dyspepsia? Functional dyspepsia is one of the digestive disorders that causes distressing gastrointestinal symptoms in the absence of disease that we can pick up by physical exam, endoscopy, radiology, clinical lab studies, all normal. And there are a number of functional digestive disorders. The top two are irritable bowel syndrome and functional dyspepsia. And there's lots of overlap. We know that 30% of patients have both irritable bowel syndrome and functional dyspepsia, but they're very common. It's estimated in studies that are done that a quarter of the general population have functional dyspepsia, have a functional digestive disorder. And with most medical conditions, only a fraction seek medical attention. But the studies that we can access are consistent with my experience in my practice. That is exclusively or almost exclusively just gastroenterology. And most of my time is spent dealing with functional digestive disorders. What does a typical ambulatory practice look like? This is not a gastroenterology practice. This is a survey of diagnoses made in the outpatient setting. This is a US survey that looks at the cost of healthcare time spent, money spent, diagnosis made. And this comes out every few years. This is the most recent study, and here's the ranking. Abdominal pain, that's the diagnosis that is on the patient's record. GERD, nausea and vomiting, diarrhea, gastritis. I mean, look at the top 10. We get quite a way down before we get to the hard diseases. And a gastroenterologist may come back and look at these and say, well, a lot of these patients whose diagnosis was abdominal pain may have had a functional disorder. Not everybody with gastroesophageal reflux symptoms has an organic cause. But this is the picture, which is very different from the picture of gastrointestinal diagnoses that are found in the record of hospital discharges. I mean, of course, gastrointestinal hemorrhage is one of the big ones, and upper GI and bleeding, a little more common than lower GI bleeding, but both are common reasons for hospitalization. Cholecystitis, pancreatitis, viral hepatitis, diverticulitis. But even functional digestive disorders make their way into hospital. Now, this classification includes motility disorders, including things like achalasia. But some persons present to hospital with abdominal pain or digestive symptoms that turn out to be functional. One of the things that I miss from my time as a hospital consultant was the time spent with the future leaders of healthcare. And these are all interns during the morning, during our morning session. And we have our show and tell. Of course, the interns see the hospital spectrum of disease. And so our show and tell, they bring their x-rays from patients seen the night before during their intake. I bring examples that may be useful from my own practice. And here at the top is a classic patient with gallstones and a dilated common bile duct. You can see the scope, and the common bile duct, which is normally the size of a pencil, is bigger than the scope itself. So even though I can't see any stones in this common bile duct, it's obviously grossly dilated. Here we've got an interesting, this was a patient referred to GI for investigation of anemia. They had had a history of some blood in the stool, but things didn't quite add up. And a look at this person's blood film shows a number of interesting features, including the fact that a lot of the red blood cells, I don't know if my pointer is showing up, a lot of the red blood cells are as big or bigger than the white cell. And normally white cells are much bigger than red cells. And this white blood cell this neutrophil has lots of lobes to it. This patient turned out to have pernicious anemia. Here's a patient with a deep aphthous ulcer who at initial presentation denied anything on the genitalia, but he turned out to have Behçet's disease. And this is a common cause of hospitalization, pseudomembranous colitis. This is a very characteristic classic picture of the colon with these yellow plaque lesions, usually caused by antibiotics, and amoxil, ampicillin, clindamycin are the big offenders. So just as these are the things that the junior doctors and interns see, the same thing with gastroenterologists. And that was my view as a young doctor, and I wanted to be a gastroenterologist so that I could learn how to find these ulcers. Look at this one, so close to the pylorix fatum. I want to find these ulcers and heal them. I want to develop endoscopy skills. I want to learn how to find and remove polyps. I want to learn how to diagnose and treat cirrhosis and cure hepatitis C. And then you run up on the this was something that I could see coming as I spent more time in gastroenterology clinic. What do you do with the dyspeptic patient who's been complaining for weeks? They have no relevant physical findings. The laboratory findings are normal or not conclusive. Endoscopy is normal. You suspect that there's no pathology to be found. You're not sure, but you suspect that you won't find anything. And you say, well, could this be stress or worry? But they deny having any stress or worry. What are you going to do with this patient? Meet one of my first heroes, Professor Walter Alvarez, who one evening, sometime in the 1930s, was giving a young clinician a ride home from a medical meeting. At the time, he was professor of medicine at the Mayo Clinic. And this young clinician was peppering him the whole way home with questions like, how do you tell a patient that her troubles are functional without her getting angry? How do you explain the presence? I felt that this young doctor was asking questions that I wished I could have answered to the consultants that were teaching me gastroenterology. What do you say when, after telling a woman that she needs rest, she answers that she has had months of it and is no better? Those questions led Professor Alvarez to write a book called Nervousness, Indigestion, and Pain. And this book was a godsend for me in my GI training, and it is one of the most valuable of my library. Long before there were Rome criteria and well set out guidelines for diagnosis of irritable bowel and functional disorders, he set this out in exquisite detail. The great Walter Alvarez. He was an interesting person. He published more than 300 to 350 papers, and one of them was a paper looking at gastric cancer in physicians. He asked the question, how good are we at diagnosing it in ourselves? And he accumulated 100 cases and looked at onset of symptoms and how long they took to come to the diagnosis. So here's our usual route based on our hospital experience. Patient presents with epigastric distress. Well, we're going to exclude erosive gastritis. We're going to exclude peptic ulcer disease. We'll exclude these things that we can look for. If everything comes up negative, we say, well, we don't see anything, really shouldn't worry too much. And I love this quote that's in my McLeod's clinical examination. You see only what you look for, and you recognize only what you know. In 1978, Manning, Thompson, Heaton, and Morris published a seminal paper that fielded the novel idea that IBS could be diagnosed by history and without doing exhaustive testing. The lead author name was co-opted, and within the GI circles, these became known as the Manning criteria. Dr. Ken Heaton pushed this research further and was one of the architects of the Rome criteria, which we're going to look at in a moment. And he's He's now renowned for his research and pioneering in that field. And the Rome Foundation that coordinates this work on functional digestive disorders now gives an annual prize, Heaton Prize for Research. Here's Ken Heaton. He was a very tall man, and I was lucky enough to have him as one of my mentors when I was presented to the Royal College of Physicians for membership. He was one of my sponsors and attended the ceremony. Heaton is also famous now for the Bristol stool chart that was introduced after I had left, and it was interesting that we used to laugh at his insistence that we had to record in detail patient's stool, only to find out that it was something that made him world-renowned. So we've gone beyond the point of, well, we can't find anything wrong, because we can find things wrong. It's just that the abnormalities that we can find are only really things we can pick up in a research lab. But the things that we can find do explain many of the symptoms of functional digestive disorders like IBS and functional dyspepsia. Things like increased sensitivity of the gut to balloon distension, altered immune function, studies that look at motility, neuropsychologic studies, CNS function studies, studies in gut flora and their alterations. These are all things that have been consistently picked up in persons with functional digestive disorders. Of course, nothing has given us the answer, but they certainly have suggested avenues for treatment and further research. Of the numerous abnormalities that have been picked up, the one that I would like to impress on my colleagues is the demonstrated visceral hypersensitivity, gut hypersensitivity. Also playing large in the symptoms that we found are the physiologic disturbances in gastric accommodation and gastric motility. But remember, please, visceral hypersensitivity. That is where most of the attention is being focused. And gut hypersensitivity, we believe, is multifactorial. There's altered CNS processing of normal signals coming from the gut. And that may be due to any number of things, perhaps anxiety, depression, and somatization is what leads to altered CNS processing, or maybe it's a primary CNS dysfunction. We don't know, but we do know that gut microbiome is disturbed in many persons with functional digestive disorders. And we know that the gut microbiome and the gut mucosal immune cells talk to each other. And so it might be that it isn't abnormal CNS processing of normal signals coming from the gut, but abnormal signals coming from the gut related to the disturbances in microbiome and mucosal function. All of this needs to be worked out. But the point I want to make to the clinician is that we no longer say there's nothing wrong. It's all psychological or psychosomatic, or it's all a great mystery. There's a lot to be worked out, but we are making progress. So what are the clinical features of functional dyspepsia? Well, it's got the same features of all dyspepsia, whether you've got gallstones or you've got atypical angina, burning in the epigastrium and pain, and they come on after eating. Eating too quickly or eating a heavy meal often brings on these symptoms. Early satiety. We are always taught that this is an ominous symptom. Of course, it speaks to the challenge that the stomach has in accommodating a meal, and any disease that infiltrates the mucosa can interfere with gastric accommodation. We worry, of course, about gastric cancer as the thing that might be infiltrating the mucosa. But the stomach that has a disturbance in the neural work, the neural signaling to the gastric muscle may also fail to accommodate. And these persons present with early satiety. And in my practice, early satiety is more commonly related to functional disorders than gastric cancer. Some persons have heartburn, some persons have nausea. But the big thing that distinguishes functional dyspepsia from the organic causes of dyspepsia is the prominence of symptoms of bloating, excessive belching, and gas. Some persons sometimes make it easy for you, and they have symptoms outside the digestive tract that are clearly related to nervous overactivity. They feel their gas moving all around the chest and back and down into their knee, or they feel tingling and pricking sensations in the limbs and jumping. Some patients tell you, well, you know, I've seen Dr. Gastroenterologist, and he told me some years ago I had irritable bowel syndrome. These are all really useful things to determine or to elucidate when you take a history. So you can't just take a GI history. It's important when you see your patient with a digestive symptoms to take a detailed and complete history of presenting complaint and past medical history. Bloating, excessive belching, and gas. Please remember that. So we've gone from, well, the Rome Foundation has now classified the functional digestive disorders into a manageable system. And there are esophageal, gastroduodenal, bowel, centrally mediated, anorectal, and childhood digestive disorders that have a Rome classification. Globus, we used to call it globus hystericus, but hystericus is not a good thing to have on someone's chart. But the globus sensation is a functional disorder. Functional chest pain. These patients sometimes move between a gastroenterologist, primary care physician, and cardiologist. The cardiologist does their workup and excludes cardiovascular disease and ischemia. And the gastroenterologist excludes erosive esophagitis. Gastrointestinal disorder, gastroduodenal disorders are common. And you know, our focus today is functional dyspepsia, but there are other functional gastroduodenal disorders like rumination syndrome. Centrally mediated gut pain is one of the less common, but still common. Less common, but still common. Patients that don't have bloating or constipation or dyspepsia, just chronic abdominal pain in the absence of disease. And I put a little star by narcotic bowel syndrome because just last month, I was referred a patient who had narcotic bowel syndrome, just recently discharged from hospital. Multiple surgeries, back scarred from previous L this and T that, fixing, abdomen scarred from gallbladder removed and appendix removed, knee scarred from multiple surgeries, recurrent, numerous visits to the emergency room in severe pain, only pethidine or morphine gives relief. And I was consulted because as soon as his morphine wore off, his abdominal pain recurred. This patient turned out to have narcotic bowel syndrome. And the only way to get him better is to get him off narcotics, not to alleviate his pain with narcotics. Rectal disorders, this is something that I come across frequently. Some with the classic proctalgia fugax, the sudden stabbing pain in the rectum, but it doesn't have to be sudden and stabbing. It could be just chronic pain. Patients can be convinced they have a fissure, but that's one part of the anatomy that's easy to inspect clearly with just a simple proctoscope. Either you have a fissure or you don't. You can see that. Of the gastroduodenal disorders, then, let's drill down on those. There's functional dyspepsia, and then there are the other gastroduodenal disorders, belching, nausea and vomiting disorders, rumination syndrome. And the Rome dons, in their wisdom, have subdivided functional dyspepsia into two subtypes: the epigastric pain syndrome predominant group and those with postprandial distress syndrome. Now, it's easy to write it down on paper. Sorting them out in the clinic may not be so easy because there is huge overlap with the two, but there is definitely a subgroup of persons whose symptoms are primarily or seem to be primarily related to problems with gastric accommodation, and their early satiety and bloating and nausea sound a lot like someone with pyloric obstruction or some other problem with gastric emptying. They present with bloating and early satiety, etc. So we call those the persons with the PDS, postprandial dyspeptic syndrome group. And then there are those who predominantly have pain, not bloating. They don't have early satiety. It wants to sound more like a peptic ulcer, stomach cramps and upper abdominal pain. But then, as I said, there is a huge overlap with both of these. The Rome criteria also specify not just the symptoms, but duration. The dyspepsia has to have gone on for more than 3 months over the past 6 months for you to make a firm positive diagnosis of functional dyspepsia. And then to sort out those persons with functional dyspepsia from those that have irritable bowel syndrome, they've added that the patient doesn't obtain relief with defecation. Because if they do, then they're more likely to have IBS, still a functional disorder, but they don't meet the Rome criteria for functional dyspepsia. And they also add that no cause is found on upper GI endoscopy. So who needs endoscopy? Does everyone need endoscopy? We recommend if your patient is 45 or over and their dyspepsia is new, then they should have endoscopy. And of course, the presence of alarm symptoms, someone with weight loss, someone with dysphagia, patient with vomiting, someone who has anemia, they should have upper endoscopy, regardless of age. So let's look at a case. We have a 29-year-old accountant, and she complains of epigastric pain off and on, and she's had it since college, but she's gotten worse since the imposition of the first emergency orders that locked us down. Her primary complaints right now are gas and belching. The pain has also moved to her lower abdomen. She sometimes has quivering in her stomach and tingling in her arms. She's been taking Nexium 40 milligrams a day for over 6 weeks. And she thinks she may have improved initially, but it hasn't given her any relief for the last several weeks. She denies being under any stress or worry, and she says she sleeps well. She did mention that she had been recently promoted at her accounting firm. Let's look at another case. These are not imaginary cases. These are all from my practice. We have a 57-year-old priest who complains of upper GI upset for 3 weeks. Is an aching abdominal discomfort, and he's got a lot of nausea. He's got a lot of bloating and gas. He's unable to finish a meal, gets full quickly. Although he's unable to finish a meal, he hasn't lost any weight and he hasn't had any vomiting. His primary care physician is looking after him well, and he has type 2 diabetes and hypertension that's well controlled. His physical examination is normal because his symptoms were of relatively recent onset, and he's 57. I did an upper GI endoscopy. It was normal. A urease test taken from a small gastric biopsy at the time of the endoscopy was positive for H. pylori. So how do we manage these patients? There are 4 main pillars: psychotherapy, stress management, dietary guidelines, medication. Again, some patients make it easy for you, and you wonder why you have to tell a patient to avoid foods that you know provoke your symptoms. But this comes every day. Doc, I knew that when I ate that conch salad that it was going to make me unwell, but I thought I really needed to have that. Wanted to have some. You eliminate all dairy. This is something that I do with all of my patients with digestive upset, whether it be irritable bowel or functional dyspepsia. And I do that because all of us are lactose intolerant to some degree. Milk is a food that's for babies, and we lose our ability to handle lactose gradually over time. Some at different rates than others. So I don't believe that there is such a thing as you are lactose intolerant or you're not. I believe that you are very lactose intolerant and can't tolerate any dairy at all, or you're a little bit lactose intolerant, not enough to give you any symptoms, and you can enjoy milk without getting unwell. And then there's a whole lot of persons in the middle. They're okay if they have ice cream maybe once a week, but not more often than that. And if you're lactose intolerant a little bit, and you have a digestive disorder, the two may combine to make your symptoms worse. So that's an easy thing to check. I mean, we can do a lactose hydrogen breath test, but I ask my patients to eliminate all dairy, no cheese, chocolate, ice cream, pizza, nothing, for 14 days and see whether you improve. Of course, you want to eliminate other things that may cause gastritis while you are trying to improve their functional disorder. You don't want them to have organic irritation on top of that. Here are 2 senior physicians one a little more senior than the other, and now my dearly departed friend. But these two senior physicians would have this required skills for effective therapy, history-taking skills, skill of having time or making time to listen to your patient, and enough knowledge. Knowledge is important. You have to have the knowledge to filter out the noise that comes with any patient that has a long history and has had lots of tests. We do enough tests, some will come back abnormal. And it takes knowledge to know, and this comes with experience as well, but it's something that we can train ourselves to do. We have to know which lab results we can ignore and which need to be pursued. Otherwise, we end up in a merry-go-round of a slightly abnormal something. So we have to repeat it, or do a biopsy, or do another scan, or an X-ray. And rather than the patient being reassured by a second or a third abnormal test, we only make them more anxious for our failure to find the cause of a test that the lab has clearly told us was abnormal. Psychotherapy is, and I'm not formally trained in psychotherapy, but psychotherapy at the bedside for a non-psychiatry trained clinician comes in the form of giving the patient information, listening to the patient, and providing support by follow-up. Psychotherapy means, for me, telling the patient that no, they don't have cancer, and that they have this condition called functional dyspepsia. Let's talk about this condition. I reassure my patients that I know that the pain and symptoms they're having are real. No, it's not all in your mind. And I explain to patients the principle of gut hypersensitivity and how you can have pain even though there's no evidence of disease. The analogy that I often use is from my own experience, the dentist office after my tooth has been drilled and filled and it's all better from the dentist's point of view. That nerve may be sensitive for weeks or months afterwards. I can't have anything cold on that side of my mouth and whatnot. And I go back to the dentist complaining about this tooth that isn't quite fixed. And my dentist reassures me, says, Harry, your nerve is just sensitive. It'll settle down. Sure enough, it does. You want to listen carefully to your patient and seek and address psychosocial contributors. We'll come back to that. And then, of course, follow-up and support is important. You don't want to tell them, I don't see anything, you've got functional disorder. Just go away. So many of my patients are really happy just to have a diagnosis. They don't want medication. They don't want any more tests. And so giving a diagnosis brings their stress level down. I mean, they've been reading all of these horrible things that can happen to you. Dr. Google has frightened them. They have a relative that tells them, my coworker had the same thing you had, Lord rest her soul. And you have to take time to go through that and explain to them, well, actually, no, you don't have the same symptoms. You don't have jaundice. You didn't lose weight. And provide that kind of support. I go through the serenity prayer with my patients. I have no special claims to divinity, but the serenity prayer is a valuable tool for our patients, to ask the Almighty for forbearance, courage, and wisdom. I ask my patients to curtail their obligations. My patients sometimes find that their stress level has gone up without them realizing it. They've taken on family challenges. They've decided to sign up to do a bachelor's or master's degree after work. They're on committees. So I talk to them about the relevance and impact that these things can have. Of course, it's important to get them to improve their diet quality and meal regularity, and we talk about that. And physical exercise. Some of my patients have gotten worse because their exercise partner has sprained an ankle or become otherwise unavailable. And they're not going for their usual walk if their partner is not there. And that upset in their stress management balance is enough to cause flare-up of their functional dyspepsia. So what about proton pump inhibitor therapy in functional dyspepsia? Most trials show some benefit over placebo, but not a lot of benefit. If persons have postprandial distress syndrome, or heartburn, persons with functional heartburn. So maybe the persons we see with what we're thinking is functional heartburn actually have actual heartburn, or some of them do, not actual heartburn, have actual acid reflux in the absence of disease, or in the absence of visible damage to the esophagus at endoscopy. So up to 50% of these persons improve with a proton pump inhibitor. Usually by the time the person has come to a gastroenterologist, they've been on PPI therapy already. So it's seldom something that I am in a position to try de novo. But I'm always able to interrogate, well, how did you do? And the main complaint is pain, epigastric pain syndrome, without things like nausea, and then PPIs are not as effective. All PPIs have side effects. They're not as frequent as some of the older drugs, but be aware that headache, diarrhea, and abdominal pain are all recognized side effects of a proton pump inhibitor. So if you have a patient whose primary problem is abdominal pain, and they have failed to improve on a PPI, you might want to consider that some of their symptoms are being contributed to by the medicine. A lot of our patients have chronic headache, migraine, and otherwise. So beware of using proton pump inhibitors in persons that already suffer from headache. And certainly it's something you want to ask about when you're balancing risk benefit. And then something that's recently been added to the things, the literature on the package insert or the label, is the development of fundic gland polyps. This is something that gastroenterologists have noted for a long time. The polyps are benign, they're not adenomatous, but they sure make the stomach look funny. It tells us that something unhappy is happening inside there. And I can always tell from an endoscopy without any history when I see a mass of polyps dangling in the fundus and throughout the body, that this is a person that's been on a proton pump inhibitor for a long time. So in my practice, when I do prescribe a proton pump inhibitor for possible functional dyspepsia, I limit the trial to 4 weeks. I don't keep refilling it. And certainly try and use the smallest dose. Some persons are on 40 milligrams or maximal dose, and they're on it for weeks and months and keep refilling it. And I don't know if that's the best avenue. What about treating H. pylori? Expert advice. Most of our published expert advice comes from the highly developed world. But some say consider it, and some recommend. If you look at the internal medicine textbooks, they all say first step is to get rid of H. pylori if they have it. If you're treating dyspepsia that may be of gastric origin. I don't know if I agree with that. Some studies, the studies that show improvement, you always have to wonder, all these conditions wax and wane. And so if someone gets better on a PPI, could that be a placebo effect? On H. pylori eradication, because you can't really have a placebo of triple therapy. So what are you comparing treatment to? A triple therapy is not benign. There's the potential for allergic reactions. The drugs cause abdominal pain. They can cause really vicious disease like pseudomembranous colitis. And those that develop none of the complications may be contributing to the community's level of antibiotic resistance. We have some data locally, 2 excellent studies published both in the West Indian Medical Journal that have provided valuable guidance. We know that 58% of our healthy blood donors have positive serology for H. pylori. And we know that blood donors are a squeaky clean population. If 50% of healthy blood donors have H. pylori, what is the prevalence in our community? And then another wonderful study done by my colleague Carter, Frankson, and others did balloon breath testing in 107 primary school children here. Median age of this group was 9, and 54% of primary school children in the Bahamas have H. pylori. So that provides useful context when a patient turns up with what I'm convinced is functional dyspepsia, and they're waving a blood test result showing that they have H. pylori and they want antibiotics. Medications. Well, I prescribe medical foods. Peppermint, ginger, and aloe have been around for well over 100 years, and they work. And there are now proprietary preparations that have peppermint, things like FD-God and Colo, I forget the name of the other things. Ginger, you can make it as a tea. Aloe, you grow in the backyard. These are all effective, especially for persons with postprandial dyspepsia syndrome. Probiotics, this is a whole separate talk. Probiotic science is under development. There are some good probiotics, good meaning they actually have bacteria in them, and there are probiotics that are like fake vitamins that have a pretty label and nothing much in them. And we still have a long way to go in elucidating gut flora and the changes and what probiotics should be used. But they are benign, they don't hurt. The science is developing, and I use them a lot. And then some persons need anxiolytics. In extreme cases, we have to attack the CNS processing issues that are related to functional dyspepsia. So as we wind down, let's look at our case 1. in this case, this patient with a long history, a stressful job, questionable other contributing factors, my diagnosis would be functional dyspepsia. She meets the Rome 4 criteria. She's the epigastric pain syndrome predominant. And with her, I discussed the diagnosis at length. I talked about stress management techniques, asked her to eliminate lactose for 2 weeks and see how she did. Got her to start exercising. Well, you know, the gym is closed, and so it was a problem, but got to find another avenue. I asked her to stop the Nexium that she'd been taking for several weeks and prescribed a trial of a probiotic and arranged follow-up for 1 month. In the priest, my diagnosis was presumed functional dyspepsia. His symptoms had not been going on long enough to meet the Rome 4 criteria, but we did do a careful history and physical examination. He had had upper GI endoscopy, so I eliminated the presence of organic disease. In his case, I prescribed, in addition to the recommendations given to the accountant, a trial of a prokinetic. Again, he was reviewed. And although his H. pylori test was positive, I did not prescribe antibiotics for this patient. So I'd like to conclude by saying that functional dyspepsia is common. History diagnosis can often be made by history alone. Endoscopy is indicated in persons who are 45 and over, and these symptoms are new, and in anyone with alarm symptoms. It's important to know that giving the patient a diagnosis and teaching them about the condition is the single most effective therapy. Everything else is support. Psychological support is a part of this, but there are lifestyle measures that are key, and medications play an important but secondary role. Thank you for your attention. Just for your reference, and I believe these will be part of the record for anyone that wants to review what's been shared. Thank you, Dr. Black.
Thank you very much, Dr. Munnings, for all that information. It's certainly a very common complaint that patients come to the office for. And so one of our questions, especially with the older age group, people come in saying, I have a nervous stomach. How do you evaluate that patient, or what are some of the things that you start thinking about or should think about when you take the history from this patient that comes in and says, I have a nervous stomach?
Well, it's always nice when a patient makes it easy for me to make a diagnosis of a functional disorder. Then I can go directly to managing their nervous stomach. I mean, the first step is affirmation. Yes, there is such a thing as a nervous stomach. The analogy I use is that stress, worry, and nerves affect us all differently. There are some persons in whom stress goes to the chest, and they are always in the cardiologist's office with palpitations. There are some persons whose stress goes to the head. They've got chronic tension and migraine. Some persons stress causes muscle spasm and chronic backache. And some persons, stress and nervous tension goes to their stomach, and they have a nervous stomach. That's a condition that treatment begins with recognition and affirmation.
Thank you. And Dr. Conville-Brown sends his congratulations. Well done, Harry. Dr. Marcia Bassett would like to know about functional dyspepsia. Do you see it in children?
Yes. but I tend to refer most of my children to Dr. Carter, who has specifically spent time learning and managing children with digestive disorders. So a lot do present to the practice, but I refer children.
Okay. Thank you. And we have a question from Dr. Grant. Other than eliminating dairy, is there another type of diet or other foods that should be eliminated? And I will just add on to Dr. Grant's question. I noticed you didn't mention anything about spicy foods, acidic foods, as we often talk to the patients about. And also, what do you think are the biggest food culprits in our Bahamian diet?
Okay. Yes, I actually spend a little more time discussing diet than perhaps alluded to in the talk. The first step is really a history. And patients will often have identified for you what foods upset them. I often begin by telling my patients who are asking me specifically what foods to eliminate that Mr. Brown, Mr. Smith, it would be so much easier if you had an ulcer. If you had something dangerous that could bleed and put you in hospital and whatnot. Because if you had an ulcer, I could tell you exactly what foods provoke gastric secretion, how long you're going to be ill for, and so on. With an irritable stomach, when the nerve is disturbed, everything upsets you. And when the nerve settles down, you'll be able to eat all of these things again that are upsetting you at the moment. So diet can be tricky. There's, some persons put themselves on a gluten-free diet. They've read about celiac disease and the subset of persons that have non-celiac gluten intolerance. And that used to be nearly impossible to avoid, but now there are health food shops if you've got the money, you can get an exclusive, you can shop at a gluten-free store. So I don't try and dissuade persons from trying to eliminate gluten, but I point out that you do not have celiac disease, and this could get expensive trying to avoid all bread and wheat, and rye and oats and barley. The question, what things in the Bahamian diet irritate the most? I think in my experience, the biggest offenders are the dietary habits as well as the specific foods. Persons fail to eat. They have a cup of tea or a glass of water, dash out, work through lunch, and at 5:30 they're having, is it dinner or lunch, dinch or dunch. I try to get my patients to eat their meals regularly. Eating late at night. So many persons tell me I just didn't have time to eat. I eat and go to bed. So it might be a healthy meal in the middle of the day, but the time that you're eating is bad. And then we know what the spicy foods are, the things that would cause gastritis in an otherwise healthy person. Tons of pepper in conch salad. Ketchup and tomato is a big offender. And we the organic cause for that. Tomato directly relaxes the lower esophageal sphincter. So if you've had minimal reflux and you've got functional dyspepsia, having anything with tomato makes it much worse. Onions, those are another offender. Does that help?
Yes, it does. Thank you. And we have another question from Dr. Ricky Davis. Given the aggressive nature of the breast cancer profile in the country, have you noticed any similar findings of aggressive or abnormal presentation of gastric malignancy in the Bahamas? And if so, how does that affect our assessment and management of dyspepsia in patients?
Yes, I've found that the incidence of gastric cancer appears to be falling, as it has been around the developing world. We are patterning the epidemiology that's seen worldwide, where the incidence of colorectal malignancy and breast malignancies are increasing, and gastric and esophageal, particularly gastric cancers, are falling. I remember when I first came home, I saw a lot of gastric cancer, a lot less now.
Thank you, Dr. Munnings. And we have a primary care question. We often see senior patients coming with a history of being on a PPI for years, and they swear by it, and they often tell you that they were put on it by a specialist. Any recommendations for these patients? Any advice on stopping this, seeing as the patient has been on this for years, the PPIs?
Yes. As with all medication, I want to limit to just what you need to take, rather than what you like to take. And so persons, I make my patients aware that these are really powerful medicines. I mean, they're so much more powerful than the H2 receptor antagonists. I make my patients aware of the symptoms, the side effects of these medicines. I mean, did you know that they cause headache? Really, doctor? I have headaches all the time. Do you know that these cause abdominal pain? Really, doctor? I've been taking them for my abdominal pain. Do you know that they cause funny things to grow in the stomach? Do you think maybe you would get the same benefit if you took just 10 milligrams instead of 20 or 40? Why don't we try that? That's my approach.
Okay, thank you. And we have a question from Dr. Francis Williams. Are you suggesting that intermittent fasting could be a cause of functional dyspepsia? If so, what is the level of association?
No, I'm not suggesting that intermittent fasting causes functional dyspepsia. In fact, there are a number of studies that suggest that intermittent fasting is a healthy thing to do.
Okay, thank you. And you know I cannot finish without asking you this question. Any recommendations, any new evidence on the effect of COVID and dyspepsia and its effect on the GI tract that we should be aware of?
Yes, not so much dyspepsia, but we do know now that COVID-19 is a gastrointestinal infection as well as a respiratory infection. And persons can present with primarily gastrointestinal symptoms: nausea, vomiting, and diarrhea. We know that the virus is shed in the stool. And so endoscopy, upper GI endoscopy, and risk of exposure from coughing and upper GI secretions are not the only risk, but the gastroenterologists and physicians that do a rectal exam and have to do a colonoscopy are also at risk in patients because COVID is excreted in the stool.
Well, thank you, Dr. Munnings, and Dr. Chin sums it up very well. Thank you, Harry, for comprehensive coverage of the topic, as well as the photos and the historical aspects. Much appreciated. Well done. So yes, thank you very, very much, Dr. Munnings, for taking the time out to share this topic with us today. And thank you to all of you for participating. Please make note of the website for your evaluation and of the enrollment key, which is antacid. The schedule still remains the same, second Wednesday and last Friday of every month at 8 a.m. Our next presentation will be by Dr. Corinne Sinqui, and it will be on the management of gallstones in patients with sickle cell disease. And Dr. Munnings, again, thank you very much for remembering our colleague, Dr. Judson Inius. So everyone, have a good day, and we will see you again in 2 weeks.
Thank you.